Welcome everyone. So this is our second case in ENT series mock. So we are discussing mock cases for practical examinations. Okay, so let's start. So we have the case of a 25-year-old male who comes to ENT OPD with complaints of bilateral mucoid ear discharge for 2 days. So he has this condition for 2 days. He has recurrent episodes of ear discharge for last 2 years, exacerbated by upper respiratory tract infections. The discharge is non-foul smelling and non-blood stained. He also has bilaterally decreased hearing for 2 years. So decreased hearing for 2 years, but feels his hearing is better during episodes for ear discharge. So now we are seeing in the right ear there is a massive perforation. Now we are seeing in left ear also there is a perforation. So now we have to um, see about the diagnosis. We have to see about the clinical examination which can be performed. We have to discuss about the investigation required for the patients, then discuss the treatment plan for this patient. So let's start. So our index case, Mr. X, he is a 25 years old male and hailing from XYZ place. Chief complaints are bilateral ear discharge for past 2 days. Now coming to the history of presenting illness. The patient was apparently asymptomatic for 2 days. Back then he developed bilateral ear discharge. The discharge was insidious in onset, progressive in nature, mucoid in consistency. So mucoid in consistency, non-foul smelling and non-blood stain, and on and off for the past 2 years, exacerbated by upper respiratory tract infection. So we can see 2 days bilateral ear discharge. So progressive incidence of mucoid inconsistency. So mucoid means some infection is there. Non-foul smelling, that means it is safe type. History of bilateral decreased hearing for past 2 years, which was insidious in onset, progressive in nature. His hearing is better during the episodes of ear discharge. Okay, so he hears better during the episode of ear discharge. No aggravative and relieving factors. Also, he has no history of ear pain, painful swelling behind the ear, ear fullness, tinnitus, vertigo, and facial weakness. There is no history of fever, headache, seizures, vomiting, and neck stiffness. No history of nasal obstruction, nasal discharge, change in voice, or post nasal drip. There is no history of cough, throat pain, pain during swallowing. Now coming to the past history, there is not a known case of patient is not a known case of hypertension, diabetes, tuberculosis, and asthma, and he's also there is no history of any surgeries related to ENT in the past. Family history, coming to the families, there is no history of similar complaints in the family. There is no history of chronic diseases like diabetes mellitus, hypertension, asthma, TB among family members. Personal history, mixed diet, normal bowel and bladder habits, normal appetite, normal sleep patterns, no history of any allergy. Coming to the general examination, the patient was conscious, cooperative for examination, and well oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Blood pressure is normal. Pulse rates are 80 beats per minute. Then temperature is febrile. Coming to the local examination of ear. So beginning with the inspection of the ear. So we can see pinna and periauricular regions are normal in both the ears. External audited canal is active discharge showing in the right ear. Again, active discharge present in the left ear as well. Tympanic membrane, they can be seen as subtotal central perforation pars tensa with regular margins. So okay, we have to mention about that, how what kind of margins we are seeing in the perforation. So regular margins and granulation tissue not seen. In the left side we can see small central perforation in antero inferior. So it is small, so we can mention about the quadrant, which quadrant it is present. So it is present in the anterior inferior quadrant of pars tensa. So okay, so when we are presenting, we have to present first for the right ear, then for the left ear. So you can see in the right side we have subtotal central perforation, and in the left side we have, it should be in the inferior quadrant, central perforation, anterior central perforation. Coming to the local examination, palpation of the ear, tracheal tenderness is absent on both the side, both ears. Mastoid tenderness is absent in both the sides. Coming to the tuning fork test, Renner's test is negative, both the sides are negative. Mbbs test is lateralized towards right, so negative because bone conduction is more than air conduction, because air conduction is having problem because of the perforation. Lateralized towards right, I mean both are affected here. ABC same as the examiner. Vestibular function test, Rombuck's test is negative, spontaneous nystagmus test is absent, fistula test negative on both the sides. Coming to the facial nerve examination for the motor function test, so we can see this is actually normal for the both the sides, right and left ear. It is normal, but if you want to see, so you can see wrinkling of forehead, to check the frontalis muscle, normal for both the ears. Closure of eyes, or to check the orbicularis oculi muscle, so able to close both the eyes. Frowning is present for the checking of corrugator supercilline. Deviation of angle of mouth while showing teeth, no deviation. Blowing out of the cheek with mouth closed, no leakage of air. Nasolabial fold is normal on the both side. Platysma is normal on the both side. Sensory function test, so test sensation over anterior 2/3 of the tongue is normal on the both sides. Nose and paranasal sinus examination. Skin over the nose normal. External framework is normal. Nasal cavity is normal on the both side. Floor is normal on the both side. Lateral wall nasal mucosa is normal on the both sides. Septum is in the midline. Now checking the cold spatula test, equal fogging on both the sides. Cotton wool test, equal movement of cotton wisp on both the sides during expiration and expiration. Examination of sense of smell is normal. Examination of paranasal sinus, there is no tenderness present. So these for checking the nasal patency test. Examination of oral cavity and oropharynx. So we can see oral cavity, lips, tongue, floor of mouth, buccal cavity, mucosa, teeth, gum, hard palate, everything is normal. Oropharynx, soft palate, uvula, anterior pillar, tonsillar fossa, posterior pillar, posterior pharyngeal wall, normal. Neck, no regional cervical lymphadenopathy is present. Systemic examination, so CVS, cardiovascular system, S1, S2 heard normally, there is no murmurs present. Respiratory system, bilateral air entry present, no added sounds. Then per abdomen, no tenderness. CNS, no focal neurological deficits present. Provisional diagnosis, so we have seen that there was perforation, so bilateral acute exacerbation of chronic suppurative otitis media. Why it is? Because there is deafness present from 2 years. So this is bilateral acute exacerbation of chronic suppurative otitis media, tubotympanic type. Active stage, discharge is this seen, so active stage with conductive type of hearing loss. So we have seen that Renner's test was showing AC was more than BC. It was showing negative. BC was more than AC. It was showing negative hearing loss. Correct type of hearing loss, both sides with no complications. Coming to the differential diagnosis, you can differential diagnosis as acute otitis media, acute otitis externa, because discharge is present, and otomycosis, fungals can also cause discharge, cholesteatoma, hearing loss. Coming to the management, so what first we'll go for the investigation. What are the investigation can be done to evaluate? So examination under microscope, the height and severity, ear swab for complications for ear swab culture and sensitivity can be done, and which kind of or what microorganism is responsible can be identified, so appropriate treatment can be given. Pure tone audiometry, so severity of hearing loss or degree of hearing loss. Radiological examination, X-ray mastoid, so basically for mastoiditis or any complications. CT scan for temporal bone. Hematological examination, case of surgery. Before going to surgery, we do hematological examination, which would check the blood group, then complete blood count, bleeding time, clotting time, etc. Treatment, what are the medical management? So we will try to remove the discharge or whatever has been lost in the ear cavity, middle ear cavity and external ear. So we'll do oral toilet, then we'll give antibiotics. So capsule amoxicillin is the choice here, 500 milligram TDS for 5 days. So 500 milligram amoxicillin TDS for 5 days. Local antibiotics, ear drops. Surgical management, that is tympanoplasty, laryngoplasty, ossicular replacement of prosthesis. So this is the surgical management. So this was our presentation again on CSOM, but this time we had bilateral CSOM and bilateral hearing loss. Thank you.